Thanks, Daniel, Alyssa, for having me. And I think kind of continuing, if I had to make a connection, I think there's actually quite a few connections with the last talk, how the U.S. healthcare system responds in situations of scarcity, health services. So happy to follow. So I'd like to talk about the experience of kidney transplant evaluation for older adults. And for those who I've not met yet, for those I don't know, I'm a nephrologist at the Seattle VA. My clinical experience related to this topic is as a general nephrologist working at the VA, so mostly working with older adults. I'm also a health services researcher and have training in bioethics. I've listed a few of my main mentors and sponsors here. There are many others, and then the organizations that support my work. I'll also give a shout out of appreciation to Manny and Cassandra, my tech team, working above their license to get a computer with all the appropriate functionality to get me hooked up today. So I'm hoping to talk about these topics through this talk. So my goal is to explore why person-centeredness matters in the kidney transplant evaluation process for older adults and what this would look like. I'll take it in three parts. We'll talk about the current status of kidney transplant for older adults, what the kidney transplant evaluation process is like for older adults, and then how do we make the process more person-centered. And also some gratuitous kidney-based art that bears little relation to the topic, but I thought was fun. So first, we'll talk about, give some context to transplant as a treatment option for older adults. And Daniel gave a really nice talk about this not too long ago, so I'm just going to go over some of the high points. We'll start with the basics. Kidney transplant is a hugely valuable treatment option for people with kidney failure, offers better quality of life, greater longevity compared with remaining on dialysis. And that's for really a broad swath of patients with different characteristics, different health conditions. And that includes older adults. So there's multiple recent studies that emphasize that transplant can be a really valuable treatment for older adults, also for people with frailty, for people with cognitive deficits. Transplant offers greater longevity compared with dialysis for this group, but also in many ways greater life participation as gauged by a range of metrics. The problem is that the majority of people will not receive a kidney transplant. So just to put some numbers to that, there's approximately 136,000 new cases of kidney failure in the US every year, 26,000 kidney transplants, mostly from deceased donors. And the reasons for this disparity are two main reasons. First, the risk of surgery and immunosuppression may be too great for some people. Based on their health conditions, they may decide against transplant. And then also, of course, the supply of kidneys from deceased donors is hugely outstripped by demand, and not everyone has a willing and able living kidney donor. Older adults are also less likely to receive a kidney transplant compared with their younger counterparts. To put some numbers to this again, while older adults make up about half of incident patients with kidney failure, they make up 27% of those on the kidney transplant waitlist, 22% of transplant recipients each year. Otherwise put, about 14% of adults aged 65 to 74 are waitlisted or received a kidney transplant within 5 years. And that compares to about 47% of younger adults. To receive a kidney transplant, all patients have to go through this series of steps. They have to connect with their local nephrologist, have an initial discussion about what transplant would mean, be referred to a transplant center, undergo a physical and psychosocial evaluation, be selected by a transplant center, and search for a living donor and or be added to the national wait list for a deceased donor. And then finally, organs are allocated nationally among those on the wait list. The great majority of research, policy, ethical analysis has been focused on this last step, on selection among those patients who are added to the national wait list, and in particular, how to make this more fair and efficient use of a scarce supply of resources. There's quite a bit less known about this, the processes of evaluation and selection upstream of the waitlist selection. This is a list of components of the evaluation process from one of our clinical practice guidelines from KDIGO. And you can see already from a distance that this evaluation process is likely, a substantial undertaking. If you'll humor me for a minute, I just want to share some preliminary data, very preliminary, from a cohort that we're building of adults receiving care in the VA that we're using to characterize steps in the kidney transplant evaluation and selection process. So this is a flow diagram or a Sankey diagram of patients proceeding through the evaluation process. Our cohort includes about 45,000 patients with advanced kidney disease that is EGFR less than 20, not receiving dialysis, and they with this kidney failure, incident kidney failure from 2011 to 19, and we followed them through 2021. And through a process of manual chart annotation and natural language processing of the VA-wide national EHR, we identified early steps in the kidney transplant evaluation and selection process that are pre-waitlisting, that are not available in those national registries. Just to point out one finding that's notable to me, of this group, about half had transplant mentioned as a treatment option in the course of care. And about a third had some sort of testing, recommendations, or treatment aimed at transplant candidacy. And to me, that's striking, because we think about transplant as affecting a relative minority of our patients because of the scarcity for other reasons. But we see here that far more of these patients are touched by the evaluation process in some way. There have been quite a few initiatives, as many of you know, over the last few years that have been aimed at increasing access and equity in the kidney transplant selection process, that have focused on increasing referral for evaluation and increasing waitlisting. Increased referrals can, I'll just point out one nice article from some thought leaders in this arena that are advocating for a sort of default to refer for transplant evaluation. So the idea, of course, is that increased referral will increase access and equity in transplant. And it is also likely that if there's more patients referred who are able to identify living donors, the absolute number of transplants could also increase. But I do think that without significant changes to availability of deceased donors, those being the majority of transplants, this kind of strategy will also mean, sort of secondarily, that there'll be more patients who experience the kidney transplant evaluation process without ultimately receiving a kidney. So on to the next part of this talk, and kind of the meat of my talk. I'd like to look at patients' experience in the kidney transplant process. I'm going to refer to a few qualitative studies that we've conducted over the last few years using different sources of unstructured data. So first, we've conducted qualitative interviews with adults over 65 with advanced kidney disease and their family members about their experience in the kidney transplant process. And second, we've extracted clinical notes from the national VA-wide electronic health record to understand the kinds of clinical assessments, decision-making, and care processes related to transplant evaluation. So I'm going to kind of pull together these multiple projects and summarize some of the themes that have emerged from this work. First, it's very evident that patients are very motivated to do what's needed to receive a kidney transplant. So transplant can promise an escape from this prospect or reality of life on dialysis, can offer a return to normalcy. And because transplant is seen as such a desirable goal, patients were often willing to do whatever was really asked of them, even if they found parts of the evaluation process to be excessive or performative or uncomfortable. As one participant put it pretty bluntly, why be worried about minor discomforts when you're having a procedure that's going to save your life? Kidney transplant also takes priority among healthcare decisions. One participant put it as, my choices in treatment were to preserve the ability to have a transplant. Everything in the last 5 years was geared toward maintaining the ability to have a transplant. Goal for transplant could also shape broader care decisions and even approach to care. And by that, I mean that engaging in the evaluation process could also require a sort of shift in mindset to focus on future risk reduction, aberrant test results ordinarily, especially for older adults and people with multiple comorbidities, might be viewed as benign or part of normal aging, were now pathologized as current or potential disease states that were to be diagnosed, evaluated, and treated. This is a quote from a patient with a prostate biopsy that had been equivocal for cancer, who felt obliged to undergo treatment. He said, "It happens to most older guys. It might not have been prostate cancer, but you've got to take care of it. Otherwise, they won't give you a transplant." And then a family member reflected on this shifting approach to what had previously been considered a benign abnormality for his wife. He said, "She's got a low white blood cell count. It's always been that way." Well, now, of course, they want to do a little deeper dive, and at any time they could, something could show up. We also saw examples of treatments for current symptomatic conditions that were deferred in favor of not upsetting a patient's chances of transplant. For one patient in the EHR, he has a long history of left knee osteoarthritis, which is debilitating. Doesn't seem that it would be best for him to have a knee replacement now that he's high priority for transplant or for a kidney. Tests and treatments that were part of the transplant evaluation process were not always benign. So especially for older adults with multiple comorbidities who are more likely to need many diagnostic procedures, the transplant process could be physically taxing, could involve complications. One example from the EHR, in pursuit of renal transplant, he underwent percutaneous liver biopsy complicated by hemophilia and occult GI bleeding. The sheer number of clinic visits, tests, and treatments could also be a barrier for some patients and families. Noted in the chart, transplant workup was begun. However, he and his family have decided that it's just too much, too many appointments, too much back and forth. Tests and treatments required as part of the transplant evaluation process could also sometimes feel inflexible or not allowing for individualization. This is a quote from a daughter of a patient who described continuing cholesterol medications, even though she didn't think that it seemed needed. Her quote was, "They said that the protocol is to have to take your cholesterol medications, even if you're not needing it. Her cholesterol, it's been pretty much on the lower end, but she's taking cholesterol medications. We don't want to be non-compliant." Local clinicians who might usually be in the position of supporting shared decision-making around this kind of care might not necessarily understand or agree with transplant requirements, but also tended to complete tests and treatments to support their patient's candidacy. One note in the chart said, per transplant center, patient's A1C is to be less than 7%, may be harmful for patients due to already present hypoglycemic episodes. The transplant evaluation process could also be confusing and opaque to patients, clinicians, and their families. Referencing back to a survey from Melissa Wachterman, who pulled together dyads of patients and patients with kidney failure and their nephrologists, she found that about 2/3 of patients, but only 40% of their nephrologists predicted that the patient will get a kidney transplant. And then another survey from Avi Gillespie showed how patients commonly didn't know where they were in the pre-transplant process. So in this survey, half of patients in the pre-transplant evaluation thought that they were waitlisted, and many of those who were waitlisted were not sure of their status. This is a really nice diagram of the transplant process from the SRTR Task 5 initiative. And it shows how there's these multiple players, patients, physicians, payers, transplant organizations, others involved in this process, and patients in this blue thread through the middle. And you see how many steps and healthcare system interactions there are for patients. Clearly a hugely complicated process. And our qualitative work reinforces how opaque the evaluation process could be for patients. Many were unsure of what to expect from the evaluation process and could even be disturbed by what felt like delay after delay. One participant described her husband's experience. She said, he waits. We've discovered that you have prostate cancer, and he ended up with radiation. And then, oh, because there's bleeding, we can't keep you on the list. That has to be treated first. And then she went on to describe multiple other experiences. And with hope for transplant, but also this uncertainty about when this would be, patients and families described deferring other life activities for periods of time in hopes that they would feel better after transplant. The same participant described how her husband put his life on hold. She said he was finally told that the transplant board rejected transplant. Actually, it gave him a little bit of relief. He decided, okay, I'm going to go down and see the kids for Christmas. That was the first time he'd done something positive in 5 years. Finally, the experience of kidney transplant evaluation and selection could take quite a psychological toll on patients and their families. Some participants did describe a sense of engagement and empowerment that they felt in completing steps in the evaluation process. One said it really feels good to know that you're accomplishing something and you're getting toward your goal. By contrast, others described what sounded like a profound vulnerability in this high stakes situation. One described it as, you feel that you have a bit of a parachute, but you don't know exactly if that parachute's going to work when you pull the cord. And another described feeling treated unfairly. She said, you've been compliant all this time, and now they're saying, so you can't have a transplant. It felt so terribly unfair. So to sum up and pull together these multiple observations about experience of the kidney transplant evaluation process for older adults, transplant can be a dominant goal, shaping other treatment decisions and approach to care. Testing and treatment tends to be aimed at comprehensively characterizing known health conditions, uncovering undiagnosed conditions, and reducing future risk in what is often organ system-based fashion. And the evaluation process could be inflexible, protracted, opaque, and could involve clinical and personal trade-offs, but didn't always offer an opportunity for personalized decision-making. So then finally, how do we improve the system to better support person-centeredness? To take a step back, when we think about the process of transplant candidate selection, we think about it being guided by these multiple principles that are sometimes conflicting, in particular, principles of utility and equity. So maximizing use of a scarce resource while also respecting equity in allocation across a population. Ethical guidelines, like the ones from OPTN, also comment on the relevance of respect for persons, but there's been a relatively narrow take on the implications of this principle. So in particular, they talk about the importance of respecting autonomy. So patients have the right to decide against transplant, for instance, have the right to know what transplant would mean for them. But I think experience of older adults that I've described here really reinforces the relevance of considering person-centeredness as a broader principle alongside these others, not as the only goal. The others very much matter, but certainly as an end in itself. I had a conversation with someone once who's poking a little bit at this idea and challenging by comparing person-centeredness to apple pie. He said, no one's really going to argue with person-centeredness. It's kind of a crowd pleaser. But at the same time, it's so commonly evoked these days that it tends to lose meaning. So I think it's important to think about a few situations in which person-centeredness is really relevant and start with these, focus on these. So person-centeredness is especially relevant for interventions with uncertain benefit and potential burdens. And as a reference paradigm situation, I found it useful to think about our experience with cancer screening for older adults in the health services world. So prostate cancer screening, for example, seems initially like a relatively benign test for an important outcome, right? Reducing risk of prostate cancer. But then there was a series of trials in the 2010s that coincided with a movement in geriatrics that resulted in this shift of approach to routine cancer screening. And the insight was that even simple tests like PSA labs can lead to false positives, can create anxiety, can lead to interventions that have complications, and ultimately may not actually have the impact, the outcome for some older adults, reducing risk of prostate cancer that we'd intended for it. And this shift led to a focus on shared decision-making for these kinds of tests to ensure that the approach to screening fit within individuals' broader goals, with their risk tolerance, fit with their preferences around longevity and quality of life. So now if we shift to the transplant evaluation process, it involves this bundle of testing, and especially for older adults with multiple chronic conditions, they'll likely go through many of these screening tests, the least of which may be prostate cancer screening. And especially for older adults, this kind of testing and treatment, because they're less likely to ultimately receive a transplant, may not result in the intended benefit that they're doing the tests for. So I think in my mind, this sets up a situation where person-centered decision-making is especially relevant. Person-centeredness is also especially relevant for people with multiple chronic conditions or limited longevity. As an example, this is a favorite paper of mine from Cynthia Boyd. She offered this example of a person in their 70s with multiple chronic conditions. So diabetes, hypertension, COPD, osteoporosis, and osteoarthritis, common enough scenario. And she went through all the clinical practice guidelines for each of these individual conditions and kind of accumulated the aggregate recommendations and treatments that this person would have in ideal circumstances. So, you know, there were pills, there were dietary restrictions, there were exercise recommendations, and of course, a bunch of clinical follow-up visits with clinicians. So, you know, the aggregate number of tasks assigned to these patients and their clinicians was ultimately unsustainable, made independent self-management and adherence difficult. And, you know, many of these recommendations could be conflicting, overly burdensome, or even dangerous. And she also notes that there's very few guidelines that are designed for persons with multiple chronic conditions happening at the same time. So of course, as I already mentioned, this population that we take care of, patients with kidney failure, is increasingly older and has disproportionate number of chronic conditions. And they're engaging in a transplant evaluation process that includes a disease or organ system sort of checklist-based focus, and also focus on adherence to standardized clinical practice guidelines. So ultimately, this kind of approach runs counter to the geriatric model of care in a lot of ways. So just to round out, I'm going to suggest a few broad strategies for making the kidney transplant evaluation and selection process more person-centered. First, there's need to build in greater transparency about what the process entails. Patients need to know what to expect so they can plan and integrate this kind of work with other care and life goals. They also need information about the likelihood that they'll receive a kidney transplant if they decide to pursue evaluation. The SRTR Task 5 group published a really nice list of unknowns that patients expressed for different steps in the evaluation process that is a nice start, a map laying out you know, how we might proceed. There's also less quantifiable, more experiential information that patients need to understand what to expect of the kidney transplant process. And just a plug for research that may be coming to a hospital near you. Our research group, so Shelley Clark at the KRI and collaborators at OHSU are starting up a project to build an online health experiences module for older adults' experience of the kidney transplant process. And in a recent grand rounds, described her work with this approach and gave an example of, I'm giving an example of a module here for a different health condition, traumatic brain injury. But broadly, these are interactive online modules that present themes or categories of experience around a health condition and are illustrated by clips of patient narratives. And that's the real important part of this. Visitors to these websites can hear stories about patients' experience. And this has been really valuable in conveying social and emotional information about a health experience and has been shown to engage and empower patients in their care. Second, I think engagement and collaboration with local clinicians will be really key. Sorry, my animations failed me just here. But this means coordinating information across healthcare settings so that clinicians know what's happening. It may also mean empowering local providers to tailor the evaluation within established constraints that are necessary to support the system. Just referencing a nice paper from Eliza Gordon and her colleagues that reviewed opportunities for supporting shared decision-making in the kidney transplant process. And you can see as an example, she suggests guiding patients and thinking about mortality and quality of life comparisons for dialysis and transplant, how those would look in the context of a patient's broader personal and social lives. And local providers, local nephrologists and primary care docs as well are well positioned to help patients navigate some of these big picture questions that are listed in this review. But to do that, they need to be informed about what the transplant process might entail, the likelihood of a patient actually completing it. To support these first two strategies, we also need standardized, evidence-based, and explicit selection criterion and an approach to the process. A more explicit list of selection criteria would give patients and clinicians a better understanding of what to expect and likelihood of receiving a transplant, could potentially limit burden of evaluation process for patients by only including those evaluation procedures that are valuable to selection. And just to throw out a few examples of this kind of evidence generation work, there's been some really rigorous study done to understand when screening for coronary artery disease, asymptomatic coronary artery disease is useful and appropriate in preparation for transplant. And also some really nice work into transplant evaluation care processes, how to organize the process and make it more efficient. This is some work from Larissa Myaskovsky, who presented at Ground Rounds a few years ago, and Johan worked on this project as well. So returning to these multiple principles that are guiding the process, certainly maximizing aggregate benefit of this scarce public resource, respecting equity and allocation are critically important. But happily, many of these strategies that I've listed here, aimed at person-centeredness, have also been proposed to support greater equity and effectiveness. So I think potentially multiple birds with a few stones. So I'll close there. I hope that we've covered these several topics. We talked about the value of kidney transplant for older adults and the fact of there being an increasing part of our population. We talked about the experience of kidney transplant for older adults, and I suggested a few strategies to improve this aspect of the transplant evaluation for this group, namely improving transparency, collaboration with local providers, and establishing standardized evidence-based criterion process. That I'll close. Hopefully there's a moment for questions, and thanks for attention.
Thank you so much, Alyssa. Really wonderful talk. Thanks for highlighting the patient experience as they go through the transplant process, and also the importance of both demystifying it for our patients and also I think there's importance for kind of demystifying the process for the providers and referring providers that play a huge role in getting these patients transplanted. So thank you. And with that, I think we have time for just a few questions here. If anyone has any, I see Justin, you have your hand raised. Please go ahead.
Hey, Kate, thanks for this. It's super interesting, thinking about from my perspective as a general nephrologist of just sort of like, I get a list of tests that sort of need to be done, and my whole thing is just like check all the boxes to make sure that they can get everything. Are there like transplant guidelines that do like the 1A, 1B, like ranking of all of the different, like the data behind the screening of tests? Or is it more of a practice pattern that people have in sort of local areas that they use to guide what things we need to do?
Yeah, that's a really good point. And I think, the KDIGO guidelines are some of the most explicit that we have and kind of summative. And there is reference in parts in that guideline to evidence base. And they also, in my mind, in my read, others are welcome to chime in, but they really are guidelines in the truest sense. They're kind of the philosophy of testing in some ways, as opposed to specifics of testing. So I think the truth is that, there's huge variation between transplant centers, and there's a certain amount of practice that may not be evidence-based in testing. In my experience, the VA has one of the most kind of standardized and centralized process of testing, and we also have kind of a checklist of specific tests that folks need to go through. But of course, there's still a huge amount of variation between transplant centers, even in the VA. So I agree. I think that's one of the main challenges, and kind of bringing transparency and awareness about what to expect from the process for patients and local clinicians too.
Thanks.
Thank you. We have actually a comment in the chat from Nikolai. Thank you, Kate. You outlined indirectly the main issue with the transplant process. You talked about pre-transplant phase from the general nephrologist perspective, but similar to other similar research with no mention or analysis of accountability, involvement, support from the general nephrologist, which is really the camouflage and sometimes sleeping quarterback of the process. As nephrologists, we really need to focus upstream and take accountability besides checking a box that transplant evaluation has been requested. But not referring to our group who has exceptional advocates for patients.
Right.
Uh,
Yeah, no, that's a really good point, Nikolai. And I've certainly the onus should not just be on the transplant centers. And I think that's been a focus of a recent policy, trying to build in some incentives, in particular for dialysis organizations and nephrologists to have some skin in the game in terms of getting folks waitlisted, at least, on a reimbursement side of things. So it does seem like that's the way that things are moving. So I'm hopeful that there'll be more kind of collaborative processes built in. And there are a lot of nephrologists I've met who certainly take, strong responsibility for getting their patients through the process. But it's hugely variable, I think, patients' experience. Yuharn, if there's a little time.
Is there time?
Yep, go ahead.
I just have a quick question, comment. Kate, I always learn so much from you, from all your talks. Just listening to what you say about, like how these patients, especially older patients, put their life on hold and all the hoops they have to jump through to get through a transplant process. One of the things that I'm thinking is, do you think we're thinking about this wrong in the first place? Like, all our lives, we've always been told transplant is the best treatment option. You have to go through this process. If you didn't go through the process, if you failed, then you're a failure. Like, this week I saw a 75-year-old patient who, I outlined what the risks and benefits, and I said, you have to decide what you want to do and whether this is the right treatment for you. And one of the things that she said to me was, thank you for allowing me to say that, because everyone was pushing me towards transplant, that I felt that, I was disappointing people when I said, this is not what I want, and I'm 75. This is not what I want.
Right. And I think in interviews, it came up among some of the patients that family was much more invested in transplant than they were. And it's tricky, right? Because you don't want to sort of disenfranchise people who need some encouragement and otherwise, wouldn't have access. But I agree with you that there's quite a almost a moral weight placed on transplant. I've been to some rooms with patient advisory groups, and they, everyone stands up, introduces themselves, and says, and I'm a transplant recipient, and there's this huge round of applause, and everyone congratulates. There's a lot of moral weight, placed on receiving a transplant, and kind of indirectly, a moral appreciation for people who have received transplant. So it's complicated. I think there's a lot of social and personal dynamics involved that you're pointing at that could use some disentangling. Thank you.
Thank you.
All right, looks like one more hand raised. Dan, you have one more comment or question?
Yeah, wonderful talk, Kate. This is such incredible work that you're doing. I have a question about whether there is quantitative data around the burden of sort of the transplant evaluation process. So, for example, like number of clinic visits, preferably like the amount of time that people spend, recognizing there's going to be quite the range. But I think that if there was some way to give people a better sense of, an interquartile range of what they're likely to expect, that could be helpful in their decision-making process.
Thank you. I hope that there is soon. That's kind of the point of this cohort that we're developing, to understand kind of timelines of steps through each of the components of the process, and also hoping to quantify some of the testing. In particular, we're focusing on coronary artery disease screening in folks that are engaging in different parts of the evaluation process, to understand that more. But to this point, I think there's very little, because we haven't. It's hard to identify where someone is in the process without information about those upstream steps. But thank you. Thanks for the vote of confidence.
All right. Well, thank you so much, Kate, for a wonderful, engaging talk. We do have a couple other comments in the chat, but for the sake of time, I think we should move forward. If you could continue any further discussion in the chat, that would be great.